Next, we will hear from Dr. Franklin King, instructor, Harvard Medical School, Director of Training and Education, Center for Neuroscience of Psychedelics at Mass General Hospital. Dr. King, welcome.
All right, hello, and thank you to the committee for the invitation to provide testimony on this very important issue. My name is Franklin King, and I'm a psychiatrist at the Massachusetts General Hospital, where I perform a variety of roles. As mentioned, I'm Director of Training and Education at the MGH Center for Neuroscience of Psychedelics, which is headed by Dr. Jerry Rosenbaum, from whom we just heard. And as he described, we are a group of researchers and clinicians united in the shared goal of using neuroscience to better understand how psychedelics can work to support existing treatments, as well as to develop novel therapeutics to address refractory psychiatric conditions. I am also running a clinical trial of psilocybin-assisted therapy, and I'm a study psychiatrist for a project examining MDMA-assisted therapy, both starting this year. And have co-developed a program called the Harvard Interdisciplinary Program in Psychedelics with my colleagues, Dr. Sholivar and Alpert, who I believe couldn't be here today but are providing written testimony. This group provides education on clinical applications of psychedelics to clinicians across the Harvard medical community. I also work in the psychiatric emergency unit at MGH. Regarding this last part of my job, working in the emergency room to address psychiatric emergencies like suicidal ideation, psychosis, and substance use, I've had a front row seat watching the unraveling of the dual crises in mental health and addictions that have been burning through our Commonwealth for years now. I am sure the sobering statistics that suicide is now one of the top causes of death in young people as well as children, and the staggering number of overdose deaths we have seen here, particularly in eastern Massachusetts, are well familiar to the legislature. I am also sure that the massive strain on all ERs across the Commonwealth, in part due to the growing number of patients in crisis waiting for psych beds that are slow to materialize, is also familiar ground. Lastly, the systems level issues facing hospitals across the country, including in Massachusetts, in part due to a massive exodus from the field by doctors, nurses, and other healthcare workers due to rising rates of burnout and mental health conditions, is likewise a front and center issue that is foremost in the minds of those concerned with healthcare and hospital policy. Let me offer my own simple perspective of what I have seen since I first set foot in MGH's emergency room as a fourth-year medical student in October 2012. At that time, our ER psych unit had 3 rooms. By the time I was a resident rotating on the service 2 years later in 2014, a new unit had been built that contained 6. This was already obsolete before it was even opened. After years of strain, in 2021, we opened a new 20-bed psychiatric emergency room that on most days has not come close to providing adequate space for the psychiatric patients in our emergency room. The numbers have simply risen too quickly to keep up. On the staffing end, in 2014, there were 2 psychiatrists working there per day. Now there are 7, as well as 4 to 5 nurse practitioners, a 450% increase in staff since 2012, actually since 2015. All this is to say, the issues that motivate me in the work of psychedelics are not theoretical. These are real problems affecting patients as well as staff on a daily basis, and I've seen it unfold at my hospital. Psychedelics caught my eye long ago because of their ability to affect dramatic and long-lasting changes in thoughts and emotions. A combination of stigma, massive legal barriers, and lack of normal mechanisms for funding has significantly hampered progress in researching these agents. However, the last 10 years have seen the publication of many clinical trials, nearly all of which have shown that psychedelics, when therapeutically administered in a thoughtful set and setting and in the presence of guides or therapists, produce significant and nearly invariably dramatic shifts in disorders ranging from anxiety to depression to PTSD to alcohol use disorder and to angst and depression associated with terminal illness. The research in psychedelics has not been without its criticism, ranging from methodological concerns, alluded to by Dr. Rosenbaum already, to the effects of the hype that now surrounds them, perhaps tainting the responses study subjects might be having when they're enrolled in a study. While psychedelics are indeed difficult to study in the way we usually study psychiatric drugs, which is to say the randomized placebo-controlled trial, and this is owing to the fact that it's nearly impossible to have a placebo group in a psychedelic study, the accumulation of data over many years is at this point simply undeniable. Psychedelics are certainly not panaceas, but the evidence that they show absolutely immense promise in addressing many of the very conditions we are facing right now, the epidemics of suicide, depression, substance use disorder, burnout in healthcare workers, and others is unquestionable. I stated a minute ago that in the studies I mentioned, psychedelics had been administered in controlled settings and in the presence of a therapist or guide. This is the way current pharmaceutical companies are looking at how to medicalize psychedelics and the strategy that will likely accompany psychedelics like MDMA, psilocybin, LSD, and DMT once they're approved by the FDA, as is anticipated in the coming years. Let me say that I am very much in support of these regulatory processes psychedelics are currently undergoing, as I believe it makes sense for patients, particularly those with severe psychiatric conditions, to have access to professionally trained psychedelic therapists. However, I also do not think this should be or can be the only option. The reasons are this. First, it is important to emphasize, again, that psychedelics are not panaceas and are also not completely benign agents. They present unique psychological challenges as well as benefits, and education is key to preventing adverse psychological harms. However, while the paradigm offered by psychedelic-assisted therapy is likely an effective one at enhancing benefit and reducing harms, there is also ample evidence from population-level studies that naturalistic psychedelic use is associated with a host of potential benefits, including lower rates of addictions and better rather than worse overall mental health. For example, an elegantly designed study conducted by Dr. John Halpern from McLean Hospital a few years ago found that within the Native American Church in the American Southwest, members of the church who partook of the peyote ceremony actually had better cognitive profiles and lower rates of alcoholism than did their counterparts who did not take peyote. Studies such as these have plenty of limitations, but what they do tell us is unequivocally that the current legal status of psychedelics as dangerous drugs with a, quote, high potential for abuse and no accepted medical use, unquote, is egregiously incorrect. We know that for classic psychedelics, particularly psilocybin, the medical risks are extremely minimal and the potential for abuse is close to zero, physiological abuse, as psychedelics produce a condition called tachyphylaxis, which means it is impossible to generate a psychedelic response after repeated doses, meaning addiction is not biologically possible. Second, the cost of psychedelic-assisted therapy is going to be extraordinary. It may ultimately be shown that psychedelic-assisted therapy is so effective over the long term that it justifies the cost for certain conditions, but many, myself included, find that unlikely. These are interventions that require many hours of therapy before and after psychedelic sessions, and the sessions themselves last for 6 to 8 hours for drugs like MDMA and psilocybin. Usually, there are going to be 2 therapists present for all aspects of the therapy. These treatments are going to require enormous upfront costs. While I, as I already stated, am fully in support of patients having options for this level of intervention if their psychiatrists feel they need it, this is hardly going to suffice for the millions of patients who need access to the benefits of psychedelics and likely do not require the strict controls of the medical model as currently conceived. This is particularly true not only for those suffering from mild or moderate manifestations of psychiatric disorders, but also for the many people who choose to explore potential benefits of psychedelics for purposes not explicitly psychiatric in nature, such as overall mental wellness, finding meaning and purpose in life, and spiritual explorations. As a psychiatrist deeply involved in both clinical practice and research, I've witnessed firsthand the inadequacies of our current approach to mental health and addiction. The statistics are sobering, with suicide rates soaring and overdose deaths plaguing our communities. Yet our laws continue to treat psychedelics as illegal drugs of abuse despite mounting evidence of their therapeutic potential. It is time to acknowledge that our current legal framework simply doesn't make sense. The criminalization of psychedelics not only impedes scientific progress, but also denies individuals access to potentially life-changing treatments. We must adopt a more rational approach, one that prioritizes evidence-based policies over outdated stigmas and prohibitions. Decriminalization alongside harm reduction and public education efforts offers a path forward that aligns with both compassion and common sense. By destigmatizing psychedelics and embracing harm reduction strategies, we can empower individuals to make informed choices about their mental health and well-being. Moreover, decriminalization opens the door to further research and innovation, allowing us to further explore the therapeutic potential of these substances. I believe it is time for Massachusetts to lead the way by adopting progressive policies that prioritize science, compassion, and public health. Thank you for your attention and consideration and for paving the way toward better policy on these important tools for healing and growth.
Thank you. Are there questions? One question. The studies that have been done, have they been done on schizophrenia or psychosis, or has it been focused on what are the kind of conditions that have been?
So studies definitely have not been done on patients with schizophrenia or psychosis or any psychotic disorder. And as Dr. Rosenbaum mentioned in his testimony, there's absolutely are certain groups of patients who should not have access to these. In the 1950s, there were some studies that were done with schizophrenia, but I don't think that's going to happen anytime soon, given what we know now of the potential risk of psychedelics in exacerbating psychosis. So, certainly I would not say that there are people who should, that psychedelics are for everyone. In my opinion, it's more a question of how we're educating the public, how we're making sure that people who shouldn't have access to them don't.
Thank you.
Yeah.
Thank you so much for your testimony and your time.
Thank you.
Oh, I'm sorry. I didn't see you. I'm sorry. There's one more question. Rep. Gordon.
In your testimony, you mentioned naturalistic psychedelics. Is there a distinction between that and synthetic? Is there a difference in the use or?
Sorry. So what I meant by that is that when you look at population level studies and compare people who report having a lifetime use of psychedelics, as in, they have taken a psychedelic as compared to people that have not, different studies have found certain associations. And there are, as I mentioned, there's a lot of limitations to population level studies, but certain studies have found that people who have a lifetime history of exposure to psychedelics have actually reported better mental health outcomes or less addictive behaviors than people who have not. So I'm not saying that it was the synthetic or naturally derived psychedelics.
Yeah, I'm asking if there's a difference.
I think some would say there's a difference. I would say we also don't have the evidence to say at this point that there's a difference.
Okay. Thank you so much. We've been joined by
Thank you so
Senator
much to the
Feeney.
committee.
Thank you.